YouTube fan since Belmont. I think my only one's my dad, and I don't know if he found my YouTube videos. It's a little bit frightening. Anyway, so I was also, I think, gave my talk like 2 months ago, so this is just an update on what's going on. I'll try to make the focus different from what you heard last time. So briefly, I'll just refresh my research questions, significance, and design and methods. Then we're going to talk a little bit about continuous versus categorical predictor variables. Then I'll go through my analysis plan and show you guys a few of the mock-up tables I made for when eventually soon, hopefully very soon, there's actually things to go in those tables, and maybe you guys can give me a little feedback on good ways to lay out those tables. So as a refresher, my primary research question is obesity associated with risk of abortion complications? And where the secondary analyses we're going to be looking at are what are the independent predictors for complication other than obesity, and is obesity associated with the risk for any individual complications? So the primary question we're looking at all complications as a composite outcome, and the secondary will be looking at individual complications. So very brief reminder, abortion is very common. 1 in 3 women have an abortion in their lifetime. They're mostly in the first trimester, about 88% for 12 weeks of pregnancy. In our population at our clinic, it's about 50-50 first and second trimester. So that's one of the major differences between the population we see and the general population, and that's because we're a big referral center. So 1.21 million abortions per year in the U.S. 34% of the obstetric population is obese. And so because abortions are extremely common and because obesity is extremely common, if obesity contributes to risk for complications of abortion at all, we want to know about it. So that's the significance of our study. And the big picture implications are that we want to help clinics implement evidence-based policies for who they see and who they refer based on complications and safety. And then to help women really is the main goal is to help women receive care in the appropriate acuity setting and at earlier gestational ages when we know that there's a lower risk of complication. And so our design is a retrospective cohort study. We're looking at all women who present to SFTH between February 2009 and April 2013. And there are just over 8,000 women in that group. We're excluding women who don't have BMI recorded or who don't have, like, you know, I can't imagine someone not having age recorded, but something like that. And then also we're excluding women whose procedures are done at our clinic in response to complications that have already occurred at outside clinics, or even that would just count as one if it had been at our clinic. And so our main predictor variable, as I mentioned, is BMI, and we're going to be looking at it probably as both a dichotomous and a continuous variable, but we'll talk a little bit about that in just a minute. And then the covariates are here. We have age, race, prior C-section, and that has been shown in past literature to be an independent predictor of complications. Prior abortion, gestational age, also an independent predictor. Adequate dilation, same thing. Placenta location, medical comorbidities, physician level of training, and type of anesthesia. And so just as sort of follow-up from some of the questions I got last time that I presented, a lot of people had questions about measuring BMI in pregnancy and, you know, is that really an accurate measure? What's it telling us? These women are pregnant, will their BMI be higher? That sort of thing. So I just found this study that showed that 50% of women have no change in their BMI category from the first antenatal visit to delivery. 44% increased by one BMI category and 6% increased by more than one BMI category. So, you know, this data only tells you a limited amount, especially since, you know, the first antenatal visit might be in the second trimester, depending on when women present to care. And also, this is delivery, so our population only going up to 24 weeks, you'd imagine a smaller change in BMI category. Additionally, like, these women might have just been closer to the cutoff and then jumped categories, whereas these women might have started, you know, at the bottom of the range. So take what you will from this data. And then also just looking into the pregnancy, BMI and pregnancy literature, most commonly, or a lot of studies will look at weight change over pregnancy or change in BMI over pregnancy, but those are often studies that are looking at gestational diabetes or perinatal outcomes or sort of like metabolic measures, because what they're interested in is like over pregnancy, what happened to BMI and how might that affect the fetus or the mother's risk for diabetes. But studies like ours that are looking at surgical procedures or exposures that happen like at one discrete time and sort of have to do more with procedural risk, we'll just use BMI at the time of presentation. And because that's what we have available and that's what we imagine other clinics will have available, and that's sort of like the most, what the clinicians are confronted with is the BMI right now, that's what we're using in our study. And then I got a question and had been thinking about last time about using BMI as either a continuous, which, I mean, BMI is inherently a continuous variable, predictor variable, or using it as a categorical variable. And so just thinking about what are the benefits of using it as a continuous or a categorical variable. So the benefit of using it as a continuous variable is that you have more information. You have only one group instead of dividing it into categories, which will decrease you lose degrees of freedom as you have to compare across more groups. You also lose information. So you lose the ability to say what's the difference between BMI of 29 and 31 if you're saying below 30 and above 30, for example. Continuous variables are good for linear relationships because most models are looking at linear models. And so when the relationship might not be linear, you might get into some trouble if you're trying to use it continuously and you're not able to assess for a non-linear relationship. And using it as a continuous variable would also do a better job if you thought BMI was a confounder. If your predictor of interest was a different predictor and you were trying to adjust for a confounder, you wouldn't be as good at adjusting for that confounding, getting rid of that confounding if you dichotomized or categoricalized that variable. So that's a lot of reasons people might be inclined to use continuous variable. Why might we want to use a categorical variable? Categorical variables you compare independently, and so you avoid this assumption that there's a linear relationship with your continuous variable. You can imagine that people at the extremes of low BMI or high BMI might not have a linear relationship, whereas like being in the middle might be the happiest medium. It's arguably simpler to present in tables and conceptually to understand because you can give an odds ratio with a clear effect size instead of making a more abstract statement about for each increment in BMI you go up this percent in risk. I think that's oftentimes harder for people to conceptually understand. And then it's an easier transition to use into practice, like giving clinicians or presenting a cutoff, even if it does have an arbitrary component to it, might be helpful for clinics in order to implement policy. And so just for interest, I looked at the past 5 New England Journal articles that described observational studies and looking at BMI as a predictor, and all 5 that I found used a categorical variable, and they oftentimes split it into 5 or 10 categories. That way you do lose less information because you have more categories, but you also lose power because you're splitting your sample size into smaller groups. And many of these studies were looking at non-linear relationships or found non-linear relationships, so it was kind of a good thing that they used categorical variables for that reason. So, I mean, I think in the end we're still going to do it both ways. We're still going to look at it categorically and also continuously because there's value to both ways, but it's interesting to think about.
And a lot of times, going to continuous is, you just lump it together, not necessarily put a unit, but put 10. Or
right, yeah, exactly.
So something more meaningful.
Right, so that you have more.
And age is simply, like, a lot of times we use age too. And so instead of saying every year increase, it's like easier to do like every 10 years or something.
So, I mean, by that, do you mean it would be still a categorical variable?
No, it'd be a continuous, but then you can just put the exponent in the model and then you can interpret.
Oh, okay.
And you can have the biostatistician help you with that too, the math.
Yes, which I will need.
But you get the power of
the
continuous, but then you can interpret it in a bigger chunk of.
Right, sort of saying like our slope over this interval was whatever it was. That makes sense. Okay, so just to review, our outcome variables is going to be any complication, and these are the complications that we defined before we started looking at the charts, and this is what they are. So hemorrhage defined as the need for clinical intervention, such as medications, transfusion, repeat surgical procedure. Estimated blood loss of greater than 250 for first trimester or greater than 500 for second trimester. Cervical laceration requiring suture repair, DIC, uterine perforation, retained products of conception, or complications related to anesthesia. And then we have another category as well. So I don't think I actually need to read through this because I'll get there anyway, but so I'm reviewing all the complications that were flagged in our big major database, and of like over 8,000, and the number that was there to review for me was 730, and so we've gotten closer since I last talked to you, or 97%. I'm missing 28 charts, and I don't know where they are. But it's kind of been a story of diminishing returns. Each time I ask for all the charts that I don't have, I get like not quite all of them, and so I'm left with these 22, and I requested them one more time, and we're kind of going to see, if they don't come this time, they're going to, I've already asked for them 2 or 3 times, so it'll just be kind of like, this is what our yield is, and then I can move forward and sort of combine. So here's just to walk you through where we are. Oops. Okay, there. So total in our time period, there are 8,800 procedures. Uncomplicated procedures, there are just over 8,000, so 8,078. We reviewed 400 of those, and we reviewed them to ensure quality outcome ascertainment, to ensure that there weren't a bunch of complications hiding in this group that didn't get flagged for our review. So we reviewed 400, and we found 4 complications that met our study criteria as a complication, which gives us a 1% complication rate in this group. So, somewhere around 80 of these we can guess might be complicated. The 730 that we reviewed, we decided that 496 of them actually met our study's criteria for complication. 55 of those were in the first trimester, and of those 55 first trimester abortions that were complicated, 17 had a BMI greater than 30, so 17 were obese. And if you put that over the total first trimester procedures, which is over 4,000, that's a 1.28% complication rate. And then these are kind of all back of the napkin calculations, and these all haven't obviously there's no adjusting, and I haven't cleaned all the data yet, so take it with a grain of salt, but it looks like there are almost exactly the same proportion of obese women in the uncomplicated group. So 31.39%. And then these are the women with normal BMI, or BMI less than 30. So of these complications, 441 were in the second trimester, and 121, so 27%, were obese, versus the 320 who were non-obese, and then that gives us a 9.8% incidence of complications in the second trimester, and 28%, so a similar percent, but actually a little bit greater, of obese women in the uncomplicated group. That was a lot of numbers. Everyone clear on that? And then, so what happened to these 231? We said they got flagged as a complication, but they weren't a true complication. So those women were procedures that were sort of overcalled or didn't meet our study criteria, and for the most part, they were women who had, really, really minor things happen, like they had cervical abrasions that didn't require repair, or they had some blood loss, but it was below our cutoff, and so they got recoded as uncomplicated. Any questions on this process slide, or does that make sense to everyone? So,
Wait, sorry, just the box down at the bottom right, 28.3%, is that among complicated second trimester?
No, okay, so sorry, it is confusing, but, so this is complicated second trimester, so 121 of 400, 121 had a BMI of over 30, obese women, 121 obese women, giving 27.4% of the complicated group were obese. And then this is how many of the uncomplicated group were obese.
So you're comparing 27.4 to 28.3?
Exactly, I'm comparing proportions of obese women in uncomplicated versus complicated.
And on the other side, it's 31.4 versus 30.9?
Exactly.
Okay.
Sorry.
Thanks.
I wasn't quite sure how to lay that out for you guys. Yeah.
Did you look at incidence of complications in the obese versus non-obese one? And maybe I'm missing.
Yeah, that's sort of the other way around to
Yeah.
look at it, and this is the way that we're going to do most of our analysis. So this is the way I presented it here, but I could flip it around and present it the other way.
Do you have a sense that the obese women have higher incidence of complications?
So I think, now I'm just gonna get all confused because I'm trying to think about this on the spot. I don't have that sense, but I'm
Then we
thinking,
can avoid
I'm
it, yeah.
thinking that it's kind of the opposite way to look at the same numbers and
Okay.
that,
This is looking, so 28%,
trying to,
I actually think you just phrased it slightly
Backwards.
differently and that those numbers are exactly what you just said.
Yeah.
I think that 28% of those with complications in the second trimester had a BMI of over 30.
Gotcha.
yes, yeah.
And 27% with, sorry,
27%.
yes, and 27% of those with complications, right, had a BMI.
Right,
Yeah.
yeah.
Go ahead.
We are not
Greg, you had
raising
another
a lot
thought.
of people with a high BMI and a low
Right.
BMI and looking at complications.
I see what
doing
you're
exactly
saying.
what you said,
Yeah.
just looking at complications and
Right.
BMI.
Yes, thank you for helping me. Phrase that.
I'm just curious about BMI as a category. So I see what you did here. It sounds like it's just two categories: above 30, below 30.
For
Do you have
the purposes of
for
this
right?
flow chart,
Do you
yeah.
have any sense of for those that have a BMI over 30? Are they way above 30 in the 40 range, or are they kind of
They're
clustered
mostly
around?
they're mostly in the 30s. It's like a very right skewed, I guess,
Mm-hmm.
distribution as a whole. So like, most people are around 20, 20 something, 28, and then the tail kind of tapers out to the right. So
Okay.
it's
So
mostly
not like a
people in
big
the
difference.
30s, and then there's a handful of people in the 40s, and then like one person at 60.
Okay.
Yeah. Okay.
Coming
Okay.
back to that, so just last question on the obesity thing, then how many people would you have then if you just looked at severe obesity? Would you see a,
Yeah, I haven't run
Yeah.
all those numbers together yet, but that's sort of what I'm gonna put together
Mhm.
for the next couple of weeks. What's the date against? But yeah, I mean, what I'm gonna look at next, so we're having a big research team meeting next week, and I'm gonna see what our numbers would be in each of the traditional BMI categories to see basically, do we have the power to do it as 5 categories, given that there'll be only so many people above 35 or above 40.
And we probably do, since we
Yeah.
have so many procedures
Right.
and our number of complications. That, I love that, like, overall, when you just look at this, this just screams out, like, the obvious point that abortion is so safe,
Yeah.
because our complications are
Yeah.
so few, but we have such a large number of procedures, and so we have such a large comparison group that I have a feeling we probably will have
Right.
enough power for some analyses of multi-groups.
Yeah. Great. Okay, so then just to think about this arm again. So we reviewed 400 of the 8,000 uncomplicated cases, which we did because we thought that was around 5%, and we'd get a good sense of what our overall error rate in that group would be. And because there were only 4, so a 1% error rate in that group, we feel like we can plan to use that entire cohort as our comparison group, even though we haven't actually reviewed all 8,000 charts. And then we'll do a sensitivity analysis to say, like, really how off could we be in this estimate if all of those 1% of women are truly complicated and, have either a very high or a very low BMI. It sort of gives us, the way I thought about it was like a confidence interval on our confidence interval, like how off could this be? And, we were actually pretty reassured to see that that was as low as it was. So that is our plan there. And so for our analysis, which is starting anytime now, soon, we're going to do it separately, as I mentioned, first and second trimesters, and we're going to first adjust or do an unadjusted analysis of all the predictors for complication, and that anyone that's significant to a level of 0.1 or less will be adjusted for in the main analysis, comparing proportions of obesity in each group. And then regardless of what happens here, we're going to adjust for these other predictors that are known in literature, which include history of prior C-sections, increasing gestational age, and race. It will be interesting to see if we also find these, to see if these are significant in our unadjusted analysis, but given that there's pretty good consensus that they're a factor in the prior literature, we're going to include them in our model anyway. And so then I just wanted to throw up a few of the sort of table mock-ups that I had and walk you through what my plan is for presenting this data. So this is our table 1, but it's also serving as our unadjusted analysis as I see it now. So we have our predictors down the side here, and these are demographic and medical history. And then here's the total, so that's your typical table 1. And then we'll have the, the mean or the N with percent here for the uncomplicated and the complicated group. And then we'll be able to see, like, what was the odds ratio of age and the 95% confidence interval and p-value. And then we can pick out the ones with a p-value less than 1 and use those in our adjusted model. So kind of combining our table 1 and our unadjusted analysis into the first table. And then this is just the second half of the table, didn't fit on one slide, but these are procedural details. And then our second table will be the multivariate logistic regression, and so we'll have our predictors that were significant here, or the ones we decided to include a priori, and then BMI, which is our main predictor of interest. And then these unadjusted odds ratios will just be pulled from table 1, and then the adjusted odds ratio will be like this, the odds ratio of prior C-section whole, like as adjusted for all these other ones. And so that's the way I was envisioning it, presenting that data. In table 3, it's just kind of a descriptive statistics for the incidence of complications, all the different complications, and then the incidence of interventions, all the different interventions. I wasn't envisioning this being any kind of comparison, just sort of a descriptive table for interest. But the other option that I was thinking of was that you could include various BMI groups here, and then compare rates across BMI groups would be an option if I wanted to make this more of a comparison table. Does that make sense to everyone? And then in table 4, this is kind of the secondary analysis I had mentioned, seeing what are the predictors for individual complications. So each column here is an individual complication. And what we include up here in the end will kind of depend on the numbers that we have. Like obviously if there's only 3 perforations in the whole 8,000 patient cohort, we're not going to include that as a column. But these major ones that are more common, I mean still very rare, but relatively more common, and that there might be individual predictors for, we'll definitely include. And so what I'm doing now is I'm merging the 2 data sets, the one that I've created from REDCap after reviewing the 730 complications, and the one that we have from the Women's Option Center database, because that is our whole uncomplicated cohort. Once those are 2 merged, which is going to happen in the next like 1 or 2 weeks, then we're cleaning, labeling, creating variables, getting it all ready for the analysis. And so big picture, if it turns out that obesity is a risk factor for complications, we're going to be thinking about ways to design intervention studies to reduce the risk, especially if there's a specific risk for a specific complication, and going from there. So I acknowledge my mentors, Dr. Kearns and Dr. Steinhauer, other research students on this project, the Women's Option Center faculty and staff, and then the CTRFP group. And if there's any other questions, I'm happy to look. But yeah, if you guys have any thoughts, basically on if you think it would be useful to add more columns to this table about making a comparison, that would be useful to me. Or if any of the ways that I laid out these tables like seemed not intuitive to you, I'd love to hear that as well. I'll show
Sometimes
you the tables.
sometimes
Next time.
in papers you can merge table 3 and 4 together actually, because you can also have descriptions in each of the, I guess, well, not table 4, I guess I was thinking about the first 2 tables where you can have, if you're looking at obesity as a risk factor, you can have in the obese and the non-obese a description while also presenting univariate and multivariate analyses, but it probably wouldn't work as well in this one.
Oh yeah, I see what you're saying, I think. That'll be something to think about for sure.
Yeah, but I kind of like the idea of having it, you can see
Separate.
what what if they're by having it with obesity and non-obesity too, and it just gives you more information. But it depends on what you find too. For table 2.
Right, exactly. Yeah.
Any
Well, I'll show
comments?
you next time.
Yeah. I think it's kind of exciting. I mean,
Yeah.
you have big N and so.
That was a question about your analysis, and it's only because you asked me a question when we were in reverse places, but how did you, how did you decide, I mean, if you go back to the slide where you're picking like the 0.1 as your cutoff, it seems like, so I get the a priori idea, but the predictive variables, which is significant with your, is it your outcome or your predictor that you're looking for that significant with? You know, like if you were to do like a chi-square, for example,
Right.
like which one are you looking at there?
So we're looking at the outcome.
Okay.
I've seen it where they did it both ways. Like, for example, they look at what are all the predictors of your predictor of interest and what are all the predictors of your outcome of interest, and then they take the overlap and adjust for those, because those are like your potential confounders.
Exactly. Yeah. And so what? Yeah. What? And that makes sense to me. Sort of meeting the qualification of being associated with both exposure and outcome. And so the way that I think I presented that what we were doing was that, if it doesn't change your odds ratio point estimate, for example, then there's something broken in that causal pathway.
Right.
But here, yeah. So what sort of pushed you to use the one, or how did you come to this? Because I've had similar problems.
It's, I mean, it's, if I can jump in, it's somewhat arbitrary.
Okay.
Yeah.
That's the final. Some people choose 0.2, some people choose 0.1. I think we were trying to be a little bit parsimonious, but still allow for, the possibility to discover different predictors. But we certainly will do some like model comparisons where, I prefer to like put a lot of things into the model and then slowly take one out one by one and sort of see how it changes the model by comparing them. And so that's probably how we'll start.
Okay, I see.
Yeah.
And then would you then save for later sort of your final adjusting variables based on those model comparisons? Oh,
Exactly. Yeah. So the final model will not be just like the static first model that
Right,
we
right, yeah.
chosen of everything that was significant at 0.1 and adjusted.
okay, that makes sense. Thanks.
Right, because you need to see if actually removing it changes your odds ratio by whatever is the conventional amount to call it a confounder. Is that sort of what you're getting at?
That's what I was getting.
Yeah.
So I was wondering if that was going to be the next step. I see how you sort of
Yes.
selected your potential confounders,
Yeah.
but then to
Right.
figure out if they're actually confounders would
Yeah.
be that whole model building.
Yes. Yeah.
Okay.
Because again, the more things you include in the model, you're
You risk
sacrificing.
overfitting and you, definitely. Good question.
And a lot of these predictors are tough to really think about because they all sort of affect each other. And there are some that are kind of provider specific, like provider level of training, and there's some that are anesthesia specific, and there's some that are patient specific. And so there are multiple layers also of thinking through what makes sense to include in the model and not overfitting and not sort of over adjusting for things that are kind of named together.
And sometimes it depends on what the reviewer wants.
Yeah.
The review is in
Yeah.
a particular area.
Exactly.
Like, so how come you didn't look at this?
Right.
Like,
Okay,
they'll force you to put it in the model.
Exactly.